Hide that. There you go. And then you should just bring up here.
Although the fact that it's not plugged in and not green is a poor prognostic sign. So maybe we'll just do this. Maybe
my audio will pick this up.
If you can't get the audio to work, that's okay. We can have some issues with that if we really see
okay.
it.
Yeah, that's live.
Cool.
All right. All right.
Okay. Well, it's warm today.
No, so I knew about this lecture. I completely forgot about your lecture.
Yeah.
She's very surgery. It's actually very similar to college. Totally forgot about text. All right, we will begin. Engage. I think we've got the slides first and audio too. So, but this lecture is called "Welcome to the Cavernous Sinus." For the next hour, I'm sort of your tour guide for those of you who learn all the wonderful things that the cavernous sinus contains and the mysterious ways in which things can go wrong. The lecture is more or less sort of a show and tell of a collection of just some interesting cases, depicting various types of pathology here, showing the diversity of lesions that can arise, and then in some cases we will spend a lot of time dwelling on some of the nuances of the presentation and the symptoms, and get a chance to discuss some of this in great detail. So we'll start with this case that caught my attention a couple of years ago now. And so this is a young, healthy 33-year-old woman who just noticed some blurred vision in her left eye. She's a school teacher, and she had noticed an episode of blurred vision and came in with this exam. Normal acuity, but that is an inferior altitudinal arcuate defect in the left eye. That pattern, that sort of area of missing vision emanating from the normal physiologic blind spot that you see is generally speaking worrisome for something at the optic disc. I mean, that's less like the way in which it emanates from the disc is just less likely to be, say, a retinal process or artifact or something refractive. We get that's sort of a hallmark of an optic nerve optic disc disease. So we look in her eyes, and they're not normal. The discs are, the red arrows show you how the disc margins are blurred, and there's sort of a chronic appearance to this disc swelling. That is to say, it's not very swollen with a bunch of hemorrhages around the disc, which is an acute appearance. In fact, there are no hemorrhages around the disc. The swelling has this kind of whitish, gliotic nature, color to it, indicating its sort of chronicity as well. And in fact, the swelling's in both eyes, although the visual field abnormality was only on the right. These arrows shown out there point out another subtlety, these sort of circumferential lines in just a few areas around the disc. I mean, the lighting may not be great for it here, but there's a few lines right here, these little corrugated areas, and right where this arrow is, there's just a couple of those lines there. Those are called Patten's lines, P-A-T-T-E-N. They can either be circumferential around the disc or sometimes radial, and they are the choroid, the back of the eye, being misshapen because of whatever is back there causing pressure and stroke. So there's swelling enough to cause papilledema or discedema, and that swelling is sufficient to create this mechanical distortion of the choroid right next to the disc as well, this Patten's line. So we expect to find something on her scan, right? She's got, well, she has bilateral disc edema. Either this will turn out to just be papilledema or it will be something local. causing disc swelling in both eyes. And in this case, it's the latter. It's not just high ICP, but there's a mass. You see, right? You see an arrow pointing here at a mass that shouldn't be there with a dural tail. So just guesses on what this is based on the appearance. Meningioma, yeah, it's not the biggest meningioma, but it's sure in a terrible place because it's sort of right there in the cavernous sinus across the planum sphenoidal. These arrows point out the fact that this meningioma is kind of creeping right up along both optic nerves, basically. So that's called the tram track sign of an optic nerve sheath meningioma, where the meningioma is around and sort of choking the optic nerve itself. And that can either be in just one eye, or in this case, depending on, it says tracked back far enough that it's crossed over, and it can be extended toward the other eye as well. So this is her optic nerve sheath meningioma. What to do about this? Very debatable. I mean, honestly, in a sort of the typical demographic, let's say, is a middle-aged woman who has a little bit of blurred vision, she has a swollen disc, you see the Patton's lines, and you get a scan, she has an optic nerve sheath meningioma. But for the most part, you might just leave it at that, because the symptoms aren't terrible, and whatever you do might make her worse. So, if the acuity has declined slowly over time beneath 20/40, then I think the scales would be tipped, and you would know you might justify to do something, and the something might be surgery, but at most places surgery is a huge risk, because if you try to resect any part of this meningioma, you're at great risk of stripping some blood supply. You can go into the surgery with 20/40 vision that you were trying to save, and come out of the surgery with no vision in that eye because you're infarcted. That happens all too commonly. So surgery is potentially dangerous in this circumstance. You could just not knowing exactly, assuming the diagnosis is correct radiologically without tissue, you could just radiate this thing if you thought that depending on how the acuity was progressing, and hope that might mitigate further vision loss. But of course, the optic nerve is vulnerable to some radiation injury as well, depending on how fractionated it does. So this is a tough situation, and this was one of the early patients I saw after I got here. And I had no experience with anyone operating on anything like this, but, and here's the lesion seen in coronal sections around both, they sort of circle around the optic nerves, is the meningioma around the optic nerves, and here it is, this big lump in the planum sphenoidal crossing both sides of the cavernous sinus. Dr. Almekti here has more experience with this type of lesion, I think, than just about anyone else, and he's unbelievably meticulous. And he and the patient sort of made a judgment to, given her young age and the fact that it was only going to grow and radiation would ultimately cause its own problems, and sooner or later, even though the acuity was fine at this stage, they judged that he might be able to operate on this with success.
Footage taken from an operation.
Here's some of that surgery.
Hours.
Yeah,
that's crazy.
An 8-hour surgery that you get to see sped up here or edited into like a minute. Here's the craniotomy. They're sort of in the orbit, sort of an orbitotomy basically at this point. And let's see, that's the meningioma. They're just slowly, ever so carefully, taking chunks of the meningioma. That arrow is pointing to the optic nerve. 1.2 million axons coming in, bringing all our vision in from that eye. Don't want it to get injured right about here. But they've stripped a whole lot of that meningioma off of the optic nerve. Just watching it makes me feel queasy because there's the possibility of infarcting that, which would be the worst possible outcome for this 33-year-old woman with 20/20 vision. But there they are, slowly going after more and more of that meningioma that is right around the optic nerve, and then they pack it with fat and close it up with the dural graft. And this is her post-operative MRI. They got a ton of the meningioma. I mean, there's surgical changes, there might be some residual tumor, but that's a lot of it. This is the pathology. This is pretty classic for meningioma. It shows all the findings you'll see on the right exam, the psammoma bodies and the whorls of the meningioma. And these were her fields, and this is how she's done afterwards. I mean, more or less, she did great. She had a little bit of post-operative double vision that we dealt with. She lost her sense of smell from all of this, which actually is a worse thing than you would think. And she's been dealing with that in terms of trying to find ways to make food appetizing. But there we are. That is an optic nerve sheath meningioma. Okay, next case. This person is much older, 84-year-old woman who's developing very slowly progressive visual deficits in one eye. So this story goes over almost 5 or 10 years. So here's a normal-looking field in 2003, and it's still pretty much normal in 2004. And there's some constriction inferiorly and maybe superiorly as well in 2006. I don't think anyone was too excited about it. By 2007, it had obviously worsened. And there's that inferior arcuate altitudinal type of visual field loss that makes you think of something at the optic disc. So she had some cupping of the optic disc, and although her eye pressures were not high, it was thought that the most likely cause of this abnormality would be glaucoma. And they labeled it normal tension glaucoma, which is the sort of unusual type where the eye pressures aren't actually high. And anyway, aggressively treated her with eye drop to lower the eye pressure and see how things went. These were the discs, so those were her right eye, correct? So I agree, the cup is bigger in the right eye. That's the cup here, and the rim is actually the right color. It's not terribly pale. So those would pass as an asymmetric glaucoma, maybe. But the following year it had worsened even more, and at this point the treating doctors just thought, if this is correct, then it is progressing kind of very quickly, and it's very asymmetric. And there's enough red flags here about the diagnosis that she got sent to neuro-ophthalmology to investigate for other potential causes. That led to an MRI scan because the main thing to look for would be a compressive lesion, see if there was an alternative explanation, and there was. A meningioma, you see a meningioma right at the bridge, the sort of sphenoid bridge there. That was her story for a slowly progressive optic neuropathy on that side. Okay, so we've got 2 meningiomas so far of very different types. One, not this one that's kind of creepy crawly, really choking the optic nerve, and another one that's just sitting right there, growing and creating mass effect compressing the nerve, as we just saw. This person, this 72-year-old person, has vision loss in the right eye. There's an interesting pattern. There's a lot of vision loss in the right eye, but in the left eye, there's some abnormality here in the superior temporal field. Anyone know what that's called? What that signifies to us? A parsimonious way to put all of that together, maybe. Well, it's controversial, but the story in many textbooks goes like this, and it may or may not be right. We'll sort of retract this in just about a second, but let me explain it. The idea is that the vision's coming in from your optic nerves, half of it doesn't cross, half of it does. But it is said by Willebrand, the German neuro-ophthalmologist, that the inferior nasal fibers in the optic nerve, they're going to cross, but before they do, they kind of mistakenly go into the opposite optic nerve by a couple of millimeters, where then they realize they're going the wrong way, turn around, and then cross through the chiasm into the optic tract. And that little bend he named Willebrand's knee. Well, we now call it Willebrand's knee or Willebrand's genu. And the reason that's important is that if, assuming that that's correct, that bend exists, you could take this combined finding of vision loss in one eye and superior temporal visual loss in the other eye and place a very, discrete lesion there. Then you obviously get vision loss in the right eye, and then the consequence of that would be superior temporal visual loss in the other eye. And that whole thing we call the junctional scotoma. So that's the description of this, if we believe it. So the junctional scotoma, kind of referring to that, here's a lesion at the junction of the optic nerve and chiasm. It in and of itself explains not just the vision loss in one eye, but also the superior temporal defect in the other eye. It's fine. We see this pattern all the time in clinic. Here is her scan. It's a big pituitary macroadenoma. It does compress that area, but it also compresses like the whole chiasm. So, and that's what turns out in most of these cases is that, it looks real nice on the visual field. And you go giving this description about Willebrand and his knee and the junctional scotoma, and then the scan looks just about like anyone's pituitary tumor that causes any variety of chiasmal problems, which is a big problem. And Jonathan Horton, a neuro-ophthalmologist at UCSF, looked very carefully to see whether or not this Wilbrand's knee truly exists or we've been fooled all along. And when you're pretty careful about it, it does not exist as a normal anatomical arrangement. It exists after you have compressed the heck out of one optic nerve, and that nerve has become totally atrophic, and now it pulls with it some fibers, and so you can find it, but not normally, only as an artifact, basically, of long-standing compression. So that's fine. Horton doesn't believe in this knee, this whole story, and I just share it with you so you know what the junctional scotoma is, and you can decide how much you want to take from that. All right, this person has vision loss in both eyes, but it's pretty clear that it respects the vertical meridian. So this is a not homonymous, but heteronymous visual field deficit in both temporal fields. And it's sort of patchy and asymmetric, and it's more in his left eye than his right eye, but there it is. This is a 63-year-old woman, okay, with blurred vision, headaches, and coarse facial features. Her wedding ring doesn't fit anymore, and her shoe size has increased by 1. And she actually, so she had some blurred vision. We found that her acuity was just slightly down, and her fields look like this. So what are you predicting? Acromegaly. This is her with her permission, and you can sort of see that there's a little bit of frontal bossing, I guess, and a slightly prominent chin. But yeah, so she had been developing slowly some coarsening changes in her facial features, and her growth hormone was 31, which is many times above normal, and the somatostatin C was equally high, and those are laboratory proof that she had a growth hormone secreted too, so acromegaly. Her scan looks like a pituitary macroadenoma, a big sort of snowman-shaped macroadenoma, growing upwards, and the rest of the chiasm is squashed right up here. You can barely see it. It's this thin rind, probably. Speaking to the fact that this thing has grown very slowly over time, and in fact, the chiasm shows itself to be pretty resistant to this kind of long, slow compression. She had fairly minimal visual field deficit, all things considered, because of how long-standing this is and how slowly it grows. But she gets resected by Dr. Laws and his team, and her fields returned to normal afterwards. So that was acromegaly. This one also, bitemporal field defects, different story. 36-year-old man, he's got blurred vision. He has prominent behavioral changes. Acuity is okay. There's a bitemporal defect. It's a little asymmetric and spills over here, so it's a little worse in the right eye than left, and he has a right RAPD going along with that. Here's his scan. Doesn't look quite like the meningiomas and pituitary adenomas I've been showing you. It's this big thing in the cavernous sinus growing upward, compressing the chiasm. It has, even on the unenhanced T1, sort of areas of different density, almost like a cystic part to it. And then on post-contrast, a very sort of ugly heterogeneous you know what that lesion might be? No? A remnant of Rathke's cleft cyst that gets really ugly and grows right there. Very good, because that's a craniopharyngioma. So when we see, the other aspects of it are pretty similar, the temporal field defect, etc. But when we see, ugly, cystic, heterogeneously enhancing lesion, we are not comfortable calling that meningioma for sure. It might be like a cystic pituitary adenoma, but we're not concerned about a craniopharyngioma, which all in all is a worse tumor to have. So these are a little too much histopathology. These are findings of craniopharyngioma. And then this case is related. So this is a 64-year-old woman, headaches, blurred vision, gets some cataract surgery. That's a common theme in many of these cases where something's compressing the visual pathways. That the first stop is some cataract surgery. That's unsuccessful, and then a little bit more investigation ensues. And so this person has the same thing: temporal defect here, temporal defect there. That's mostly superior, and so of course we're worried about a chiasmal lesion. And this is it. It does not enhance, actually. You see that it's sort of, the whole thing is cystic, but there's this cystic thing here that's expanded the pituitary sella. It's growing upward. There must be some mass effect on the chiasm. Their fields prove it. Here it is in the sagittal view. And so this thing is actually a Rathke's cleft cyst. It's like the cousin of a craniopharyngioma. lot less bad happening. But the explanation for both is that many moons ago, when you were like a zygote or something, there was some kind of tube that was supposed to involute, and it had some pharyngeal tissue or something, and then those remnant cells that were supposed to become your pharynx, they stayed up north of that. And then now, if they transform, they can either just grow and become this Raphke's cleft cyst, which has on pathology that columnar epithelial sort of cell architecture, which is like pharynx basically, but growing here. Or it could be worse and more complex, and that's the craniopharyngioma, where it's not just a simple line epithelial structure with a cyst, but has even more elements to it. Okay, so Raphke's cleft cyst and craniopharyngioma, all possibilities for things that grow right here. So this was her pre-op fields I showed you. She had the Raphke's cleft resected. I just showed you the pathology, and then post-operatively the fields got so much better. Okay, this woman we're going to dwell on for a while. So this, because of how much she teaches us about the ways in which a cavernous sinus lesion affects. So a 46-year-old woman with loss of peripheral vision. Here are her absolutely textbook, severe, complete bitemporal field defects, right? How could it possibly be that? But here we are. I'll make several points about it. So we look in the back of our eyes and we see the following. The discs are slightly pale. You'll take my word for it. The asterisks kind of show you where the distribution of where there's some pallor. And so really, in the right eye, there's some pallor here. Inferiorly, the color of this nerve, of this tissue looks good. It's orange and pinkish. Temporally, it's kind of pale again, and superiorly, the color is a little better. We get like real subtle about describing where the nerve has some pallor and where it doesn't. And maybe to a lesser, maybe this is less convincing, but it's pale here, and again, there's a little bit of sparing superiorly and inferiorly. So if we imagine, it sort of looks like these little bow ties sitting here on the optic discs, these bow ties of pallor. The neuro-ophthalmologist will describe it that way. They'll say, this patient has bow tie optic pallor. And it's sort of code among us for what that means and what it, how we're going to think about this and localize it. So I'll share that with you. Why would you get bow ties on your optic discs? Well, here's her scan. It's, there's no surprise about the localization. In this case, it is common enhancing, and it's a meningioma, just a plain meningioma growing at the pharynx, stomatidae, and compressing the heck out of their chiasm and giving her bitemporal field defects. Well, let's try and think about why these little bow ties show up. So the explanation is as follows. I mean, here is your right optic disc and a bunch of blood vessels, and here's the right fovea in the center of your retina. Similarly, here's the left optic disc and the left fovea in the center of your retina. And although there's no like anatomical landmark really, there is a virtual vertical meridian right there in your eye. And functionally speaking, it matters a lot. Because if you're a ganglion cell that lives on this side of that line, you're going to have a very specific destination when you get to the chiasm, whether or not you cross and so forth. And if you are on this side of the vertical line, then you have a different destination, right? So this vertical line, although it doesn't actually exist, it does functionally, and it matters a lot. So we can think about how axons are making the first pass, getting from their origin to the optic disc, so then they can get out of the eye and go where they need to go. So in each eye, there's the temporal half of your retina, if we take that virtual vertical meridian right there. And then there's the inputs from the temporal part of your retina. And those inputs, if you can see here, the way they get to the optic disc is they arc. Either they swoop either up or down, as the case may be, but they arrive at the superior and inferior parts of your optic disc. That's how you collect all this information from the temporal half of your retina. Everything to the side of the line, demarcating the fovea. And then you have the nasal retina. The disc is actually somewhere in the nasal retina, right? And so inputs to the nasal retina arrive on both sides of the disc, either on the temporal side of the disc, or the stuff coming straight from the fovea. But then retina on the other side of the disc has to come in too, and that comes into the far, to that nasal side of the disc. All make sense? So that's how axons first get to the disc and then work their way back. And then, like I mentioned, either they're going to stay ipsy or they're going to cross, obviously, if they're coming, depending on whether they're coming from nasal or temporal retina, and then go backwards to the future. But if you have a giant chiasmal lesion from the meningioma I just showed you, then basically you're disrupting those crossing fibers selectively or disproportionately, and you've deafferented the nasal retina in both eyes. Hence, you have bitemporal visual field defect. So the nasal retina is now deafferented, gone. Everything there is dying. Those axons are being lost. But the temporal retina is still fine. That's seeing. And so those inputs still arrive at the superior and inferior parts of the disc. But everything that's lost and atrophic is the stuff that was trying to come to the nasal and temporal parts of the disc. And so when you look at the disc with sort of that much level of specificity, you can see how the little bow ties show up right there in the superior and inferior parts. Not the most important part in all of neurology, but one day you'll see a bow tie like that maybe. You'll think about where it localizes. The more, I think it just sort of speaks to like the whole organization of this vertical meridian and the fact that, you know, in adders, even though it isn't there, the organization is pretty predictable in terms of how stuff is arriving from a certain part of the retina and then where it gets to the disc. And so, you know, with this OCT machine we have, we can measure the actual thickness of axons in the eye very carefully, that retinal nerve fiber layer on the innermost part of the retina. It's demarcated by those red lines. And the point is, when we create a map of how thick your retinal nerve fiber layer is going around your optic disc, in a case like hers, this is her OCT scan, the same bow ties show up. She has a lot of thinning. The red is bad, it's too thin. And a lot of thinning nasally and temporally. And because her temporal retinas are spared and they swoop their inputs in, this temporal superior part of the disc and temporal inferior part of the disc is totally normal thickness. That part of her retina and optic disc is completely fine. That's the other side. Okay, so the next aspect about this patient is the following. So we've got her bow tie pallor down. We're expert on that. Now we're going to deal with a symptom she's describing to us, which is a little hard for that heart brain symptom. So she's telling us that she's got the following intermittent, double, and sometimes missing vision. So here we go.
Okay, try to describe the scenarios in which you notice some trouble with your vision.
So when I was walking over to my dog's bowl, I got confused for a couple of minutes because it looked like there were two instead of one. And then when I'm unloading the dishwasher, I would think I grabbed 3 forks and it was only 2. And then again, when I was putting them in the compartments of the drawer where we store the silverware, I would get confused as to whether I was putting 3 forks or 2. It would look like 2 sometimes, or if it was 2, it would look like 3.
So the count would be off?
Yes, the count would be off.
Are there other examples where that happens?
I would be looking at the table and think I saw 5 almonds on the kitchen table, and there would be 4.
Okay. Really?
Yeah.
So it's not even just double vision. It's not that 1 is 2. 4 could be 5, or 4 could be 6, or 4 could be 2, and she looks at this stuff and she sees a bunch of forks or a bunch of almonds and has trouble with figuring out what the number is, right? So how do we make sense of that? This is sort of what she's describing. Another patient had with the same symptom, bitemporal. She's really upset by this because she'd look at you, and while she's looking at you, you look like you had 2 noses in the middle of your face. And while she was looking at you, suddenly your nose would disappear. And this was a theme of sort of a fun house, and it was really distressing to her. It would sort of look like a Picasso or something. And what she was describing was the same phenomenon. What all this represents, this unusual symptom, is called penny-field fly, which we don't have, but when you have bitemporal field defects that are dense, it can occur. And so this is basically the explanation. So if you are looking, here you are looking at something in front of you, like that orange star, and obviously the way things are wired, set up is that, you know, what's to the left in your left hemifield is seen by both eyes. It is seen by the nasal retina of the left eye and the temporal retina of the right eye. And that's how you create your left visual field, and then vice versa for your right visual field, and so forth. There's a lot of overlapping vision. There's a ton of overlapping vision. There's only small crescents of vision at the very periphery that are seen only by the ipsilateral eye. But everything else overlaps, and we use a lot of that overlapping vision to make sure that our eyes are lined up, to sort of give us some automatic feedback about, to reduce any drift of our eyes. When we're like very, very tired at a talk or something, or at a post call, then that mechanism, falls apart, and you sort of get a little bit of that doubling and everything while you're just before you're ready to call it quits and fall asleep. But for the most part, that overlapping vision is part of the system, and it helps keep our eyes lined up together. If you have dense bitemporal defects, then this is the consequence. You are only left with the nasal field seen by each eye. So the left visual field is the nasal field seen by the right eye. So your right eye is seeing this half of your vision over here. And then the right visual field, shown in red, is the nasal visual field for the left eye. So your left eye is seeing this nasal field over here. You got these two nasal fields, and they're good. They provide a reasonable amount of vision straight in front of you. But nothing overlaps anymore, because you don't have any temporal fields in one eye overlapping with the nasal field for the other eye. So what you're hoping is that these two intact nasal fields meet perfectly at the center. And then you would have a nice, coherent visual experience in front of you. If those two nasal fields came right together in there. Your eyes would have to be perfectly lined up for that to be the case. However, if your eyes drifted even a little bit, so if they turned inward and esophoria, then these two pieces, these two nasal fields that you've got would actually just be pushed in that direction, and you wouldn't know it. I mean, you wouldn't know that that something just changed. The experience would be suddenly your nose would just disappear, the nose of the person you were looking at. Or 5 almonds were on the table, but you only counted 3 of them for some reason. Count them all, because the middle 2 were gone. Because they were in that spot that is this, it's kind of just philosophically interesting. This thing can be right in front of you. It's just gone. But similarly, if the eyes drift outward, then you've got your 2 nasal fields. You're hoping that they meet side by side without a gap and without overlap. But if your eyes have drifted apart from each other, like an exophoria, then it turns out these 2 nasal fields have been dragged one on top of the other. And again, you wouldn't really be able to tell, except that you'd have this doubling of vision right now. And so your vision would constantly be shifting in this way. They can shift vertically, too, where one nasal field is sort of just drifting up and the other one down, depending on how your eyes are lined up vertically. So basically, these 2 halves are just kind of floating the whole time. And you can see how that would be disorienting. That explains for something. Yeah, exactly. Yep, so you close one eye, that whole funhouse thing goes away, and you just have a nasal field to deal with. And you've got everything else is missing. But at least what you've got is reliable. Exactly. So there we are. So just to illustrate how disorienting it would be, for example, if I had bet on a football game with Dr. Samuels and lost, and we had plenty of money, and I was about to write him a check for $1,000. And as I'm writing this out, all those zeros are there, and I kind of need to get the right number. But when I'm looking at it, it might look like this or like this. And this is actually the experience of kind of things always shifting around. They get, the patients get, they're affected by that. So that's part 1. That's any field slide. So you haven't heard about that yet. It is kind of one of the more interesting ways in which a bitemporal hemianopia can mess with your vision. This is the next part of it. It's called post-fixation blindness. So we get a very careful history to a person with a bitemporal hemianopia, depending on what activities they're trying to do and find frustrating. You might hear this. So when you are looking at something close in front of you, your eyes are converged, so you can look right in front of you at this thing. And so you see these like 2 beacons coming out of each eye, right? Like each eye has its nasal and temporal field that I've shown in blue and red. But they're converged on this target so that the fovea of each eye is looking right at that star in front of you. But if you and so when we do that, a lot of that vision is overlapping because of the way our temporal field overlaps from one eye overlaps with the nasal field of the other. But if we now take away the person's temporal fields with this dense bitemporal hemianopia, what happens is that they have the intact nasal field for the left eye and the intact nasal field for the right eye, and those are coming together. But if you look at how the temporal fields are now, the missing temporal fields, where in fact they're subtracting vision from this patient, everything behind the point of fixation, everything immediately behind the point of fixation, only lies in the temporal field for each eye, which is weird. But there's the geometry. It's true. So she can see what the star, but she can't see anything behind the star. Everything, when she's converged on that star, everything behind it is just gone. So, for example, where would this symptom come up where they are affected by the fact that they have post-fixation blindness? It would be from trying to thread a needle, is one example of many. Here you are, you're a seamstress, trying to thread a needle. You look at the needle, fine, but now you shift your gaze a little bit and you look at the thread. You want to look at the thread and bring it toward the needle, but every time you look at the thread, the needle just disappears. It's gone. You try and look at the needle, but now you can't really see. I mean, the thread's not, you're not focusing. Every time you try, so this would become frustrating. This is called post-fixation blindness. You would ultimately have to learn to look at the needle and just like bring the thread to it. Because you look at the thread, the needle's gone. Okay. Other cases here, this one we could probably skip. This is a sad one. So this 34-year-old man, I didn't see this coming. He simply came to me with some blurred vision. He told me he broke his glasses. So it turns out that his vision was 2400 in this eye, and there's a central area of vision loss. The acuity is driven not by peripheral parts of your visual field, but what's happening dead center. So he has missing vision in the center, and he has poor acuity here, and that's primarily his symptom. But I was struck by the fact that there was also missing vision in the other eye, and this sort of respected the temporal, the vertical meridian. And so I got worried, like all the cases I've been showing you, about something. Although he hadn't realized it up until now, and it was sort of pseudo-acute relating to his broken glasses. Maybe in fact this has been going on for some time, and there's something in the chiasm. And it was horrible actually. The chiasm is here with the red arrow. It's 2 or 3 times the size it should be. The chiasm itself is too big, and arising from it is this horrible enhancement and a mass, and the whole big, large, enhancing mass is not just the chiasm, but the hypothalamus as well. And sadly, this is a glioblastoma. It's a chiasmal hypothalamic GBM. See here. And this is the pathology after the resection showing the GBM, necrosis, and pseudopalisading. And about a year later, he passed away. This is a once-in-a-lifetime case that we actually published the image neurology. So this is a 52-year-old man. I'll just show you for show and tell. I don't think we'll see this again. This man lost vision he's now reporting blurred vision in his left eye. But the immediate history is that he had gone blind in his right eye from a retinal detachment. So some weeks earlier, he went blind in the right eye. They found a retinal detachment. They tried treating him for that. A variety of procedures were done to try to save vision in the right eye, and it was unsuccessful. So that's sad. But now he has vision loss in his left eye, and so immediately they're worried that that's also a retinal detachment, but it isn't. The fundus there actually looks fine. And the fields show that it really respects the vertical meridian, again, sort of taking you out of the eye and wondering if there's something further back. So this just teaches you a little bit about how the ophthalmology of how people deal with a retinal detachment. So you see his right eye here. See how it's different from the left? The right eye is where he had the retinal detachment. So in treating a retinal detachment, you go and do emergency surgery and try and glue the retina back on, and now you've got to do a variety of things to try to get the retina to stay there. You might put like a buckle behind the eye, but a common thing that's done is after you've done this retinal reattaching surgery and you're hoping that it might salvage vision, you need to do something to get the retina to stick. And so you inject the eye with something, often a gas. You inject this gas, this inert gas, into the eye itself. Do a vitrectomy, remove all the vitreous, put this gas in there. And then depending on where the retina was actually formed, and you actually instruct the patient to spend like 2 days with their head in some sort of position so that the gas is up. The gas is up, pushing the retina up against the back of the eye. You can put some oil in there as well, some silicone oil, but that's it. So that's what they did. They put that fluor, whatever, some kind of inert gas into his eye. And he had an infection, and they had to go in and do another and release some of the gas, and then they had to go in and put some antibiotics because they thought they created an endophthalmitis infection. A bunch of needles went in and out of his eye. They were trying to get the retina attached. But if you see here, unfortunately, one of those needles probably punctured the back of the eye. The gas escaped. So the gas you see tracking in, it is actually in the optic nerve going all the way back. And here in this picture, the gas is actually like in this chiasm. So and in the ventricles, so that's, so the reason now that he has lost vision in the right eye, that we understand, but the reason for the temporal field defect in the left eye is an unusual one, which is that there's gases actually tracking back from the eye into the chiasm. All right, we're behind the chiasm now, and we're going to work our way to the optic tract and make the following point. So for the most part, your chiasm is above your pituitary. Your optic nerve comes in, and the tract is behind it. There are variations. So in a proportion of patients, they have what we call a post-fixed chiasm, meaning the chiasm is a little bit further back. It doesn't matter if their optic nerves are a little longer. The only reason it matters is if they get the same pituitary tumor as the other patient, their pituitary tumor is going to cause more anterior problems, like an optic neuropathy more than a bitemporal chiasmopathy. That's all. We just have to be prepared for any variation on this theme. Similarly, if the chiasm is so-called prefixed with short optic nerves, that's fine too, just that the same pituitary tumor as it grows is more likely to cause perhaps an optic tract abnormality, which will look different clinically than a chiasm, than chiasmal pathology. And this is what it looks like. So this 64-year-old woman was describing vision loss to one side. It was, in fact, a homonymous defect she was describing rather than vision loss in one eye alone. You see it's in the left field for each eye. And so when we encounter a homonymous visual field like this, especially an incomplete one, this is a left visual field defect in each eye, but it isn't complete. The next question we want to know about it is whether or not it's congruous. And that's this. So that's to say that this person has an incomplete left homonymous hemianopia. Homonymous being on the same side of the vertical meridian for each eye. But it's incomplete. That means that for one eye, the left field defect is much bigger than it is for the other eye. And the way we conceive that incongruous homonymous hemianopia is that it has to be retrochiasmal. There's no debate of that because it's homonymous. But it's probably pretty anterior, like the optic tract. Because in the optic tract, you're getting 500,000 axons from one eye trying to find their buddy among the 500,000 axons in the other eye. And by the end of the optic tract, they're paired up and they're like coming together, representing basically the same point in space. But that's a lot of magic that has to happen in the optic tract to find, for each single axon to find its partner. And so early, like in the more proximal optic tract, if you have an incomplete lesion, you can disproportionately get more of the fibers that have either crossed or more of the fibers that have not, but either way, a varying amount. Once lesions are placed further back, like retrogeniculate lesions, you get homonymous hemianopias that are congruous. It's very hard for that. For the most part, these are hard and fast rules, but that's the general rule. All right, so here's her lesion. She has an optic tract lesion. We knew it would be there because she has an incongruous homonymous hemianopia. It has not been biopsied because it's like part of the tract, and we think it's a small craniopharyngeal, but we've just been watching it. All right, so that's a lot on different ways to compress your optic nerves and optic chiasm and optic tract. And there is another side to this, which is efferent stuff. So coming the other direction, you have a third nerve that, I'm not going to bore you with this, we'll skip it. You have a fourth nerve and you have a sixth nerve. And as you know, the third and fourth and sixth all lie here in the cavernous sinus. And so they are vulnerable to many of the same lesions I've just shown you, right, on the efferent side. The third and fourth are on the wall of the cavernous sinus. V1 and V2 also lie on the wall of the cavernous sinus. 6 actually floats inside the cavernous sinus, very near to the ICF. Okay. So this woman is from the double vision talk earlier in the year. She has double vision. Let's see if we can just figure out what the double vision is from. She looks to the right, looks okay. She looks to the left, I don't know, looks okay. I'll tell you that she looks up and down, does look okay too. Is anyone convinced of what her problem is just by looking at that alone? Not quite. So what would you like to do to find out why she has double vision? How do we finesse this? Yeah, Maddox rod or alternate cover testing to just see if she has a misalignment. Because we did eye movements, and I don't know, she didn't vary the sclera, but you're like really going to stake your whole reputation on whether that's going to vary the sclera. So you want more than that. So you want some kind of alignment testing, not fixed rod or alternate color. So here we go. She's looking straight ahead. Is that an ESO or an EXO? ESO. The eyes are, there is a misalignment, they're inward, and every time I uncover, it has to go from an inward position out. So, lo and behold, she has an ESO, but a lot of people have an ESO. So we still have to figure out whether or not this has to do with why she's reporting double vision. So what do we want to know about her ESO? Yes, is it comitant or incomitant? So we're going to check it in right gaze and left gaze. And if we see, even qualitatively, the same amount of ESO, that's comitant. It's a little less exciting. But if we see that it is much greater, the amount of ESO is much greater in one direction than the other, that would be incomitant. And I think that would be pretty good proof that she has weakness of the lateral rectus on that side, like to a partial sixth-nerve palsy that we've been uncertain about up until this point. So we got the little bit of ESO in primary gaze. We now have her looking to something on the right. And I don't see the ESO there at all. But I bring her over to the left. Big ESO. The eyes are really having trouble lining up here. And when I do this test, I can see how much they have to go from an inward to outward position, which is an incomitant ESO deviation, greatest in left gaze. This is weakness of the left lateral rectus. I mean, it might be a partial left sixth-nerve palsy if it's not more peripheral than that. And her scan is perfect. There's a little meningioma. And it happens to be in the perfect spot to affect the sixth nerve as it's entering the Dorello's canal or having entered Dorello's canal and now coming into the cavernous sinus and the partial sixth. Okay. I think that's for time here today. So this case from like a year or two ago is a 53-year-old woman, and we'll work through the diagnosis here. She had she's from Bermuda, I think, presented with a sudden apoplectic severe headache and double vision. Here she is looking to the right. She looks good. She looks to the left. What do you see? We don't need Maddox rods and ultimate cover testing here. She has the left sixth. She looks up and she looks down, and those things are fine. So she has a left sixth. This is subtle, but I thought there was a little bit of anisocoria, just a little bit. The pupil measures 3 millimeters here, and it's slightly smaller on this side. It's 2.5. Okay. There's also, maybe you believe me, like a trace of ptosis on this side as well. All right, so I don't know. You could write all that off. That could be physiologic anisocoria. Everybody has a little bit. Ptosis isn't that good. But what eye drop test would you like to do? See if this is all just physiologic, or if she in fact has sympathetic dysfunction in a Horner syndrome. The answer is there. It's an apricot test. That is apricot work to confirm whether or not this is a Horner syndrome.
Discussing medicine.
Let's hear it.
All right, so it's a weak alpha-1 agonist strong alpha-2 agonist. But I think the main thing is that on the eye that if there's a sympathetic fusion, then there's denervation sensitivity, supersensitivity. So from a molecular level, like the receptors will be upregulated. So then if you put on apricot, that people will dilate more, so get reversely anisocoria. Alpha-2 also acts to on the other eye to suppress a little bit of damage.
That effect is much.
But not as important.
But that was a perfect explanation. So this drop, typically speaking, is a very weak direct sympathetic agonist. That is to say, no one uses this to dilate your pupil because it doesn't really dilate your pupil. It doesn't do anything. But if you have physiologic anisocoria, it's still not going to do anything. But if you have Horner syndrome, because of the concept of denervation hypersensitivity, you got receptors there that are starving for any sympathetic input, anything noradrenergic, and even this little weak apreconidine agonist will create some dilation, and lo and behold, that's what happens. She has reversal of anisocoria after the drop. It's like an experiment with a control arm built into it. Put the drop into both eyes, and an hour later, the right pupil has done nothing. It stays 3 millimeters, but the left is actually dilated. So the point of this is that she does, pharmacologically proven, have a subtle Horner syndrome. And that curl is that 6 nerve palsy plus Horner syndrome equals cavernous sinus. Because the 6 nerve palsy can occur from any variety of places, all along, starting in the pons all the way up. But there's only one place where the sympathetics and the 6 are that close together, and it's right in the cavernous sinus, because I told you the 6 is like floating next to the ICA, and where the sympathetics are coming up on the ICA. And ultimately, they piggyback on other nerves to get into the orbit. They piggyback on B1 to get into the orbit. But right there, the sympathetics are very close neighbors with 6. And so 6 plus Horner's equals cavernous sinus. So you get to scan it. And there's this big thing that is hyperdense on CT. So what do you think that is? Big hyperdense thing in the pituitary in the cella that is presenting with sudden awful headache and double vision. Yep.
So Shank, it's Lee. Can I just ask you 2 quick questions?
Yeah.
The first is oculosympathetic palsy as opposed to true Horner's in that location. And then the second one was she slightly ESO-deviated in the left eye in primary gaze? Or was that just the picture?
Yeah. I mean, correct me if I'm wrong, but I equate those. Oculosympathetic palsy is, it more or less is Horner syndrome.
Well, no, without the anhidrosis, though. So once it's traveling up the internal carotid, the fibers that go to the face have gone out on the external carotid, so you wouldn't get the anhidrosis.
Absolutely, I totally agree with that. That's right. So this is a portion of the full Horner syndrome. And so in this localization where you're obviously a third-order neuron, because we're in the cavernous sinus, you will have no anhidrosis accompanying that. And the deficits are only the pupil. That's correct. Because the rest of that pseudomotor innervation to the face, that stuff really comes on basically there, right at the origin of the third order neuron. So right after that synapse, you have a lot of this ascending the ICA, but the stuff going for sweat in the face basically has come up the ECA. So with carotid dissections producing Horner syndrome, you don't get, similarly, you will not have facial anhidrosis as a component. I agree with that, Lee. And then to back up to the picture, the left eye doesn't abduct. That's about all I think we can safely say about it. Oh, when she's looking here, I think you mean. It's hard to see. The left eye doesn't abduct, but she has an incommon ESO deviation greatest in left gaze for sure. Whether it looks like the right is inward or not actually has more to do with which eye she prefers fixating with, and it's too easy to get fooled by kind of just which eye she was fixating with when I took the picture and so forth. And so I wouldn't overinterpret, whether there's a problem of movement in the right eye just based on the appearance of alignment during anyone's photo. But what she has is the left 6 then, sympathetic lesion. It's sort of part, but not all, of the full Horner syndrome. And here's this. And this is what it looked like on MRI. Does anyone want to say what they think this is? Big mass that bled and is in her pituitary cella and created an apoplectic headache. Double vision. Well, I'll tell you that she showed up in the middle of the night, and people looked at that, and I think they looked at this. I don't know how carefully they looked at this, but they thought this is apoplexy. This is a macroadenoma that was undiagnosed and bled. And that should be one of the first things that comes in your mind, and you will see it as a legitimate neurologic emergency at some point on consult or something like that. Sudden headache, we start thinking about subarachnoid hemorrhages and Paul Fleming and all these things come to mind. But apoplecsy's got to be on that list, and so it's the reason why patients should have should include visual fields and eye movements and things like that, because if you're looking for apoplexy. So they go to the operating room first thing in the morning, and they do their transsphenoidal approach, and they remove dura, and they are now looking right at that mass right here. And this is what they said. So the mass is like pulsatile, and they get this Doppler and put it on it, and it makes a very scary sound. Exactly. This is the surgeon has soiled himself. I think there's a story actually I've heard of Harvey Cushing being in the exact same scenario, going into operating what he thought was going to be a big pituitary nephron adenoma, only to find out in the operating room that it was a partially thrombosed aneurysm, and just throwing everything, having the greatest fit of his life, and just soaring out of there, and that's it. Never to. So that may or may not be true. Our surgeons were much more responsible about it. They realized what they were against. If they went one step further to begin the process of removing this thing, they would have, the aneurysm would have ruptured, of course, and she would have had a horrible hemorrhage. But they stopped right there. They then proceeded to do more MR angiogram. Shows us this ICA aneurysm that we now know she has. A catheter angiogram is done. And they have to make decisions about how to treat this gigantic ICA aneurysm. And so you might try coiling it and so forth, but there's going to be a higher risk that you lose your internal carotid when you do this. And so to prepare for that possibility, they do a test occlusion. So they do a balloon test occlusion of the ICA, and they do SPECT scans kind of before and after that occlusion occurs. They talk to her while the ICA is occluded, and they see how good her circle of bullets is, because if she has a good enough circle of bullets that she can supply her MCA on that side despite losing this ICA, then they can make the decision that they might have to sacrifice the ICA in trying to remove this aneurysm, which is actually happening. So that's that. And this is the very last case, and we'll wrap up. So this is a 27-year-old I saw who was describing episodes of double vision. The backstory is that 5 years ago, he had just legitimate, persistent binocular double vision lasting days or weeks, and a 6th nerve palsy was found, and he got worked up with imaging, and they found a chordoma. Chordoma being something that arises in the clivus and is again, embryologic remnant of your notochord, which was supposed to go away, but in this case did not, and now has transformed into something sort of malignant. So they found a chordoma, they operated on it, and they radiated. He needs radiation too after the surgery. So all that happened when he was 22 years old, and he's been in pretty good shape since then, and 6th nerve palsy went away after the surgery and the radiation. So now, 5 years later, he's understandably very anxious because he's begun noticing some double vision again. So immediately, even before I got to see him, he got a scan. And here's the scan, and it just shows all the stable, this is the preoperative MRI. And then this is the recent surveillance MRI. Nothing's grown. I mean, this is just the same postoperative MRI he's always had with changes in the clivus, but no recurrence. And so at this point, it wasn't clear why he was having his symptoms. He had a pretty stable MRI for what that was worth. Okay, so here he is describing exactly what he means by brief episodes of double vision. It's a neat diagnosis.
And sometimes when I wake up or look off to the side, I get double vision for a little bit when I look back.
How long does it last?
Lasts no more than a minute or two.
Can you make it go away during that?
I cannot make it go away, but then it always goes away on its own.
It just goes away.
Yeah.
Being normal. Okay, so look at my finger here. Now come over to the right. To the right. That's where he used to have a 6th nerve palsy. It's fine. This is the side where you used to have a 6th nerve palsy, but that's what I still agree. And you come back. Okay, we're going to the left. Double vision. Everything's starting to look up. Back. And look down. And back. All right. So now over to the left. That's fine too, right? Okay, so we can't find anything that's wrong with this third or fourth. No double vision right now. You're on my finger and it looks okay. He stays out there for a while, and now that he comes back, what's wrong? The eyes are exodeviated. The left eye is like cramping. It's stuck over there. It won't relax. It's uncomfortable. Keep trying to look right at the camera. He's trying to wait for that left lateral rectus to finally relax. It finally focuses.
It's definitely still double.
Yeah. And this whole time it's double. It's fine on the double vision. You just set the right at the camera. Look at my finger. No more double vision right now. Okay, that was it. Oh, so you guys just gave it away. I treated him. So now that you're taking the medicine, when do you get the episodes of double vision?
I'm only noticing them way in the afternoon, evening. I'm only taking the medicine most of the morning, and I've chosen so far not to take it in the afternoon as well. I can usually trigger it if I really want to earlier in the day, but I'm not just noticing it in my everyday life before then.
So what was that? Why did I give him oxybate for that? So he he's had a history of some kind of tumor. He got radiated. Everything was okay. Now he gets these episodes of double vision. The eye movements are full and the eye alignment is actually normal. However, if he looks in a certain direction for some period of time and then just tries to look back, that eye actually is not weak. It's too strong. It got stuck over there for 30 seconds until it relaxes and comes back. That's called ocular neuromyotonia. And virtually all the time it occurs with a preceding history of radiation. It's impossible. It's very hard to find a case that doesn't have radiation as the cause of ocular neuromyotonia. And the exact mechanism is that something went wrong with some sort of apoptic firing. I'm going to call it a cramp to be very casual, but there's an excessive contraction without relaxation there. Whether that's the nerve or the actual motor unit, it hasn't been studied carefully enough to know the true underlying physiology. But things like carbamazepine or oxybenzepine are better. So we did that. He takes it in the morning. He gets a little bit of this symptom late in the day. It's up to him how much he wants to take. If he wants to take it in the morning and afternoon, he can. If he's happy with how things are going with just morning dosing, that's fine too. I was like dying to know why he had so much of this in the morning. He like had a lot of this double vision first thing in the morning, and so the explanation is as follows: is there? You saw how he triggered it, looking to the left. Well, his nightstand is on the left side of his table, so the alarm goes off. And he's doing this, trying to reach his phone, shut off the thing. And he's like, crap, I have double vision. So, in addition to giving him oxybenzepine, we took the nightstand, put it on the right side of his bed, and his mornings were much better for me. So that is a bunch of stuff in the Cavernous Sinus. Thanks, guys. I don't think so. Because it's not like you'd have to go into a muscle. Yeah, you can put it into a muscle. Yeah, I think I don't know. I haven't seen that done for that.
Thanks so much.
You're welcome.
I'm gonna hit to end the broadcast or it ended itself.
That doesn't look as
Usually
promising.
it's on a separate
Yeah, maybe there's a different window.
PowerPoint.
Stop, right.